It's not just that we have an aging population, it's that we're doing them more frequently because the risk-benefit profile has changed over the years. This was a much, much different procedure, 20, 30 years ago. So we were a little bit more hesitant when we offer joint replacements. I'm sure a lot of you have seen advertisements like this, and this just kind of, again, reflects how it's becoming more and more common. And by 2030, it's estimated that, over 600,000 hip replacements and over 1 million knee replacements will be performed in the United States alone. So worldwide, the number is pretty massive. But like I said, the point of this talk is to kind of go through different aspects of it, where we've come from, where we are today, what are the considerations. And I think a lot of the advancements over the past, at least 20 years or so, are kind of highlighted by, our understanding of the anatomy, and that's kind of led into different techniques that we use. One of the most talked about topics is usually the anterior hip approach, so that we'll get into detail about that as well. The materials of the implant, we've learned quite a few lessons over the years and how to design these implants. And then really kind of things that impact your experience undergoing a hip replacement. In terms of pain management, the medical management, therapy, your stay in the hospital. I think if any of you had a joint replacement, 20, 30 years ago, you probably would have stayed in the hospital 3, 4, maybe 5 days. A lot of people were going to rehabs at that time. But we've learned a lot from that. One of the things, why we always encourage folks to, our goal is to get them home after a joint replacement, is because we've seen that if you go to a rehab center, your risk of infection goes up. There are a lot of sick folks at those locations. So that's why, we've learned that, getting people home and in their own bed is ideal. So to start off, certainly understanding what is arthritis is certainly, essential. So if you look at this hip over here, it's a good, healthy looking hip. And one of the things that we're looking at is the joint space right here. That's cartilage that doesn't show up on x-ray. So the cartilage is the smooth surface inside the joint that kind of cushions the joint and protects it from seeing abnormal force, which would result in pain. So that's a good, healthy looking hip. Now you compare that to the left image where you see no more space there. So that's what we call bone-on-bone arthritis. And there's a lot of different reasons why people end up with arthritis. You have your general run-of-the-mill arthritis, which is predominantly genetically determined. So a lot of people will come in and say, yes, my mother had a hip replacement, my brothers did. And ultimately they ended up with arthritis as well. But you can also have different conditions. Inflammatory arthritis, that's more associated with things like rheumatoid arthritis. You can have previous trauma which damaged the cartilage and kind of led to a breakdown of that over the years. Avascular necrosis is a condition where the bone kind of collapses in on itself. A majority of those cases we're not actually sure why it happens, but we have associated it with chronic steroid use, high doses of steroids, things like that. Alcohol abuse can certainly lead to it. And then finally, infections. If you have an infection in a native hip, that can lead to a pretty rapid breakdown in the cartilage. So that's more of what we consider an emergency in orthopedics to try and prevent arthritis from setting in if you have an infection. So how does this present? How do people feel? The typical presentation would be groin pain, usually activity driven. But I always like to say, not every hip has read the textbooks. So some people will come in and feel a little bit more buttock pain or pain in the side. Sometimes it can extend into their low back as well. Some of the other symptoms, limited range of motion, that's more of an early sign of arthritis. Typically, moving your hip in and out is usually the first to go. And then more late stages, people start feeling that their hip is giving out on them. They don't trust it. And that is certainly a concerning sign because, our primary goal is to, prevent any falls or additional, damage. And that's really your body's way of telling you, hey, that hurts, we should stop doing this. So no more high impact activities is what your body is telling you. Some alternative things that we consider when patients come in for hip pain, certainly referred back pain is probably the most common. I do have a handful of patients that kind of bounce in between spine surgeons and hip surgeons when we're trying to figure out, where all the pain is coming from. Because all the nerves that go to your hip, that go to your knee, they all originate in your spine. So if the nerves get irritated in your spine, then your brain says, hey, that's the nerve that goes to my hip. And that's when people say, my hip really hurts, but their x-rays look great. Their spine looks, pretty worn down. So in those cases, we have different, little tricks that we can do to try and figure out, if it's really coming from your back or your hip. But unfortunately, a lot of patients will have what we call a two-hit phenomenon, where they have issues radiating from their back to their hip, but they also have underlying arthritis. And I think it's important for patients to know that, if you do undergo a hip replacement in the setting of back pain, that might not take care of 100% of the pain. It certainly would improve it, but if we don't address the back as well, then you're left with those symptoms as well. Other things, trochanteric bursitis. What that is, if you look at these x-rays, this little bony prominence really kind of sticks out, and you have a lot of soft tissues on the edge here. So if those are tight, the soft tissue gets irritated. Most of those patients will come in and have pain right on the side of their hip, usually painful with direct pressure on it. And that's more of a pretty straightforward, simple treatment with physical therapy, trying to loosen up those the soft tissue on the outside of the hip. You also have muscles that insert in this area. Those can certainly have little tears in them, a little irritation. And then just some muscle strains. There's a lot of muscles around the hip. Those can also present as hip pain. Again, all pretty simple things to treat with physical therapy and activity modification. So ultimately, when you're diagnosed with arthritis, the $1 million question is, what do we do about it? All right. So there are two main options. One is to try and treat the symptoms. The other is try and get rid of it. And so typically, with the risk-benefit profile, risk of symptomatic management is close to zero. Obviously it's a quality of life thing, but if you can get your quality of life improved with simple measures like physical therapy, over-the-counter, pain medications, activity modification, so whatever makes it hurt, don't do, that can certainly help out. And I have had patients signed up for surgery, they go to physical therapy, they come back and say, doc, my hip pain's so much better, I can still do the same things that I want to do. So it's certainly worth trying those modalities. Injections are a question that often come up. The mainstay, what we provide a lot for joint pain is cortisone. It's a great medication, pretty low risk profile. But it's my perspective that it's a great option for knees, back, shoulders, anywhere else. Unfortunately, with the hip, it comes with an additional risk factor for what we call rapidly degenerative hip disease, where you put a little cortisone inside the hip, and then all of a sudden, your arthritis is 10 times worse, a few months down the road. We're not exactly sure why it happens, but it can happen in about 5% of patients. And in my training, I've seen it enough that I don't want to see it again. And I don't think that the benefits really outweigh the risk with the cortisone in the hip. So that leaves us with, talking about surgical replacement. Now there's 5 criteria that you have to meet to start considering a joint replacement. So first and foremost, you have to be diagnosed with arthritis. So your symptoms have to correlate with your x-rays. Certainly you should try symptomatic management, and if that's not working, then it's certainly a conversation of next steps. It should certainly, bother you on a daily basis. And then a key point is that your expectations meet the outcome. So, what can a joint replacement, provide for you? I always think back to one of my patients that told me he wants to go heli-skiing after a joint replacement. So, low impact activities are kind of key afterwards. I always equate it to, buying a new Porsche, that you're going to keep the rest of your life. Certainly you can go off-roading with it. It's probably not going to work as well as you want it to, and it will probably break down, sooner rather than later. So that's why we say, be gentle with it, keep it on the road, treat it nicely, and it will treat you nicely. So, that's making sure that we meet your expectations with those. And lastly, being medically fit for surgery. Most patients don't have issues with anesthesia. Some do. That's certainly a concern. But the main considerations are really trying to minimize the risks associated with a hip replacement. So infection is kind of top on our list of things that we want to avoid. And thankfully, they're around 1% or less. So it's very rare to have an infection in your hip, but it's certainly possible. And the things that we know put you at risk for that are uncontrolled diabetes. So as long as your diabetes is relatively well controlled, then you should be out of that risk factor. Tobacco use, that has complications with wound healing, and if your wound doesn't heal, that certainly puts you at risk for infections. And then weight, unfortunately, and the things that we go off of for that is your body mass index, so your height to weight ratio. If it gets above 40, then your risk of infection goes up about 4%. Now, some people might look at that and say, 4 times what it is. So if it's 1%, then it turns into 4%. Some people might look at that and say, well, I have a 96% chance of doing okay. But, infections can be certainly a devastating complication that we want to avoid at all costs. And weight is something that we can modify before surgery. So that's always our goal, is to modify your weight before you need a joint replacement. And the implants themselves have, again, come a long way over the past 20 years or so. So hip replacement has a number of components to it. There's the cup here that goes up into your pelvis. There's a plastic liner. It's a very high quality plastic. There's the head component of it that sits onto the femur, and then this is the femoral component. So if you see here, the femoral component sits into the femur. The femur is kind of like a PVC pipe, and it kind of gets stuck in there, and then over time, the bone grows into this, rough area of metal, and it really kind of solidifies things down. So things that we've learned, titanium metal has been shown to be the best for implants. It's not the strongest metal we have, but if you go for the strongest metal, then it kind of shields the bone from being used. And if your body doesn't use it, then it starts to absorb it. So titanium's the closest thing to bone and doesn't really have that issue. Highly cross-linked polyethylene, so that's the plastic component of it. So about 20 years ago, we manufactured this a little bit differently, and we would start to notice a little bit of a breakdown in the plastic over about 15 years or so, and that's when people would start to get more and more revisions because they would have complications with the plastic component. They developed a different way to manufacture them, so the plastic piece that we use now really has negligible wear associated with it, at about 20 years. So that's probably the biggest advancement that we've made that's had a huge impact on the longevity of hip replacements. Other things, using ceramic heads. We still use ceramic and metal. Both of them have great, wear profile. It doesn't wear down the plastic. It's very, very smooth. Dual mobility is when the head is connected to that plastic piece. So that vastly decreases the rates of dislocations. And then the design of the implant itself. So one of the newer ones is a triple taper design. So it's big and bulky up top and then kind of skinny down low. And that was designed specifically for the anterior hip. It's had a great profile. It's had a great, track record of survival compared to some of the other ones that sometimes would slip down or sink down into the femur a little bit. So the implant itself has come a long way. The big thing that comes up a lot is the anterior approach versus the posterior approach. So personally, I do probably about 70% anterior hip replacements and about 30% posterior. And I'll go into my reasons why in the next slide. But the anterior approach is right up front there. It's about a 10 centimeter incision. It splits the muscles, so it kind of goes in between them, so you're not cutting anything. And then you get right down to the hip, and then you can replace it. That approach was actually developed and designed, about 30, 40 years ago. But as people got better and better at it and adjusted their techniques and changed some things based off of anatomy, that it's become much, much more popular over the past few years. That's in comparison to the posterior hip replacement. That's been kind of the most popular approach to the hip. It's a very good approach. There's not much, wrong with it. It's a little bit of a bigger incision, but I certainly think both of them are great approaches in the right hands. So diving in a little bit deeper into the anterior versus posterior, the pros and cons. So focusing on the anterior approach, like I said, it's muscle sparing, so you're not cutting a lot of the muscles. And what that does is protects you against dislocations. In the posterior approach, you take down some of the tendons that help stabilize the hip joint. You do repair them at the end of the case, but it takes time for those muscles to kind of scar in. So you're at a elevated risk of dislocating for the first few months. The reason why I personally really like the anterior approach is that I have access to x-ray the entire time during the case. So when we're putting in our components, we want it in specific angles and orientations. So if I'm looking for 40 degrees on that cup portion of the component, I'm shooting x-rays the whole time, so I can see and get it within a few degrees of 40 degrees. I still take x-rays during the posterior approach, but it's a little bit more cumbersome and much more limiting. Just so I don't get any surprises in the recovery room when I get final x-rays. And in terms of patients, why patients really like the anterior approach a lot better is that it has, with all of our literature, has shown to have a faster recovery. So at about 6 weeks, people are doing a little bit better than folks that had the posterior approach by a couple of weeks. So in posterior approach, folks might still be using a assist device, might still be taking some pain medications. But at 3 months, everybody is pretty much equal. And I think in the grand scheme of things, if we're looking at, the long-term 20 years, a couple of weeks is really not that big of a downside. But it's certainly nice for some patients to have less pain and more mobility after a hip replacement. The downsides to an anterior approach, so the anterior and posterior do have equal rates of complications. But the anterior has more specific complications associated with fractures. When we're putting in the implant, the bone can break. It's not, a huge deal. It's certainly, we're able to fix that, during the procedure itself, but certainly not what we're looking for in terms of a routine hip replacement. And then the big one would be wound healing. And that's the reason why I do about 30% of my patients posterior, is because if you have a little bit more soft tissue up front, if you have a little bit more of a belly, that incision is right in that crease, and that can lead to wound healing complications. So in those patients, I really talk to them about minimizing the complications associated with a hip replacement, and that's really the reason why I encourage them to go ahead with a posterior approach. Again, the posterior approach is the most common approach. It's a very good approach. The rates of dislocation have actually been shown to be equal. But I would say, the anterior approach is easier to get what you're looking for, whereas the posterior approach really kind of depends on, the skill of the surgeon. So a well-done posterior hip is just as good as an anterior approach, but it's a little bit, trickier to get the components exactly where you want them. It's a lot more versatile, so if you have more bone loss or a more complex hip, that's certainly the way to go. You have great visualization. You can put in pretty much any type of implant. The one that I showed earlier, again, was specific for the anterior approach. Posterior approach, has a number of different implants that you can use that can kind of address any specific concerns that we would have preoperatively. And there's really no contraindications to a posterior approach, so no issues, with extra skin up front there or anything like that. The downsides of a posterior approach, I think, posterior hip precautions are a little bit of a downside post-operatively. And what those are is that you're limited. We don't want you bending your hip past 90 degrees. So that, comes into play when you're getting up from a seated position and you're leaning forward. We don't want you turning in or crossing over midline. Those are the three kind of components. And those are really essential during the first 3 months. That's when most dislocations happen. Like I said, it's because the muscles are starting to heal and scar in, and those protect you from dislocations. It's my perspective. I'm a little bit more conservative. I tell my patients that if you can adhere to those precautions lifelong, it would be probably in your best interest. And for a lot of patients, it's not really a big deal because if they have bad arthritis, they're probably not putting their hip into that position anyways. You're not doing deep squats or anything like that. And then, like I said before, the anterior approach has a little bit of a faster recovery compared to the posterior hips, but in the grand scheme of things, they're about equal at about 3 months. Now, this is really a slide about how far we've come over the past 20 years and how patients are doing so much better with these procedures and why we're doing them more often. Is because people do well with them. Like I said, 20, 30 years ago, you would stay number of days in the hospital. A lot of people would go out to a rehab facility. But the medications that we've figured out that kind of help patients recover and feel a lot better has led us to the point where we can do same-day surgeries, where some folks, are going home right after surgery. The first one is tranexamic acid. That's something that was developed by the military. Kind of worked its way into trauma surgery and finally found its way to joint surgeons who figured out that if we give this medication, it really limits blood loss and that decreases the stress on the body. It decreases rates of blood transfusion after a surgery. All really good things to have. I use steroids in a lot of my cases. That limits post-operative swelling and pain. Multimodal pain management, we've come a long way. Again, 20 years ago, we'd rely heavily on opiates, and the more that you take of one medication, the more side effects you're going to have. So patients would get confused, they would get lightheaded, some would have falls after surgery. But we figured out if we, give you multiple pain medications, so anti-inflammatories, Tylenol, we do nerve blocks, we do local anesthesia. We tend to minimize the amount that you get of any one medication. That limits the side effects. So that's had a big impact as well. Anesthesia, things that you can expect if you want to go a hip replacement. A spinal block is kind of our plan A. What that does is allow anesthesia to kind of numb you from the waist down so you're not feeling any bit of the surgery. Then they give you just a little bit of medication to kind of make you sleep through the process. That's in comparison to general anesthesia, where you get intubated. There's a tube down your throat, which can cause some irritations after the surgery. You have a lot more medications on board, so you wake up a little bit more groggy. But people do ultimately fully recover. It just takes a little bit longer. So spinal's our plan A. If you need to do a general, it's not terrible, but it's certainly a plan B. And then physical therapy, getting up same day of surgery, getting up and moving around has been shown to really improve long-term, outcomes. We tried bed rest for quite a few things back in the 80s and 90s, specifically spinal injuries and things like that. And we just started noticing that people were getting more and more complications when we recommended bed rest. So we kind of swung the opposite way and said, we got to get you up and moving. So physical therapy starts, day one of surgery. That certainly has made a big impact on getting people home. Most of my patients will stay one night in the hospital working with physical therapy, making sure that they're safe to go home, that they're stable on their feet. Younger, healthier patients, possible same-day surgery, go home the same day. When you do get discharged from the hospital, you'll have a visiting nurse, a physical therapist to come visit you at your home, make sure that you're getting around okay, make sure you're not at risk for falls. Usually my patients will use an assist device initially and they'll wean off of it as tolerated. So whether that's a walker or a cane, usually they're off of it about 2 or 3 weeks. Then I see you in clinic at 2 weeks just to make sure that the wound is healing appropriately, address any questions, any concerns. At 6 weeks is when people start to really feel much better. I have had patients, go back to manual labor jobs at 6 weeks. It wasn't necessarily my choice, but it's certainly feasible. And then at 12 weeks, just to kind of check in on you, see how you're doing, if there's any last lingering issues, then we address those, and then I see you yearly after that. Um, so that's the kind of general gist of it. And then certainly a big question is, what can I do after a hip replacement? Like I said, it's buying that new Porsche. Um, so one question in terms of driving, obviously that's going to be dictated by, whether it's your left or right side. There's no specific criteria other than you have to be off of opiate pain medications. You can't drive a car when you're taking opiates. So once you wean off of those, then it's, how you feel, how you're doing, and how quickly you can react. Usually people get back to driving at about 4 to 6 weeks. In terms of activity, again, low impact activities are always what's recommended. Things like golf, doubles tennis, pickleball, hiking, swimming, biking, anything like that. Certainly, well tolerated with a hip replacement. Skiing comes up on occasion. That's certainly a little bit more of a discussion. Certainly impacted whether or not you had a posterior or anterior hip, and whether or not you'd be compromised in certain skiing positions. Typically when you're skiing, you're kind of crouched down. So if you're really crouched down, you might break that 90-degree rule. Your knees are together, so we don't want any turning in of the knee as well. So that certainly is a little bit more risky with the posterior hip. The other aspect of it is falls. We never want to fall. With your regular hip, that can certainly end up with a hip fracture, but that's a little bit easier to fix than if there's an implant in there and it breaks around the implant, then that's a much bigger procedure, a little bit more involved in terms of trying to fix that and get you back to your baseline. So. That's certainly a little bit more high risk if you're doing black diamonds and might be at risk for a fall. Certainly no moguls, but it's certainly how you feel, and you would be limited by if you feel great you can do it. If not, then steer clear of it. Yeah, so that's certainly a consideration. Ultimately, to diagnose osteoporosis, you have to have specific X-rays. Sometimes you can kind of anticipate that on plain X-rays. It's certainly something that we can manage, but we look at it in the operating room while doing the procedure. If you have osteoporosis, we can kind of tell that during the procedure how soft your bone is and how stable the implant is. And if there's any concern, then we just use a different implant that is cemented in there. So my main criteria is whether or not you have more soft tissue up front there. So if you have a little bit more of a fold in your belly, then that gets me concerned about wound healing issues. And like I said, I really want your complication rates to be as close to zero as possible. So in those cases, that's when I would recommend a posterior approach. Like I said, the other aspect of the posterior approach is it's much more versatile. So if you have, underlying, previous fracture or hardware in there or anything like that, where it might be a little bit more difficult to get, just a regular primary joint in there, then the posterior has a little bit better, access to everything where you can make adjustments, put in different implants if you need them.
Is there an age cutoff?
Not specifically. No, not. It's mostly your medical comorbidities and your activity level. The big thing is one is getting through the surgery, which I think most people can tolerate. For a majority of people, not everybody, but a majority. But the other thing is recovery period. To gain your strength back. It does knock you back a step or two with the anticipation that you'll go 10 steps forward. But if you're at a point in your life where you can't tolerate a step or two backwards, so if you're in a wheelchair or anything like that at baseline, then I would certainly be a little bit worried about your recovery period. Not typically. Like I said, most of early arthritis, your bone starts to develop bony spurs and things like that. And let's see if we can bring that one up. What happens is that it's a ball and socket, and so if you have extra bone growth around it, the bone's going to bump into the pelvis, and that can be a source of pain, specifically with how you position your leg. So there's no real golden rule about positioning other than whatever is most comfortable for you.